Hi there, I'm Dr. Nadu Tuwaku, and over the last 30 years I have taught students from Johns Hopkins, Bowie State, Catholic University, University of Maryland, and currently Georgetown medical students. Of course, lots of things have changed during this time, but one thing remains the same, and that is that you need to be able to present your history to your attendings and colleagues in a concise and informative fashion. Whether your history is collected with an iPad or any other electronic gadget or written by hand, the fact remains that you do need to present your patients so that people can understand exactly what is going on with them in the most concise fashion. Have you ever marveled at how some students can present a patient and get to the root of the history in 3 minutes or less? You may have noticed that some students present their patients to the attendings, and the attendings just smile and ask very few questions. On the other hand, there are students who present a patient and it's like an inquisition. They're hammered with a variety of questions. Well, with practice, you can minimize the number of questions that your presentation generates. This video is simply about presenting the history that you have already gathered. It is not about how to take a history, because that is covered elsewhere. Presenting a history is a skill that must be learned regardless of the specialty that you plan to go into. It's sort of like conversation. In some ways, it's an art. Yes, you need to know your facts and science and what parts of the history are important, but the concise presentation is an art, one that you should learn and practice. I'm going to give you some tips on how to develop the art of clinical presentation. Basics. State the name, the age, patient married, smoker, last time he was healthy, presenting complaints and duration of symptoms. Is this the first occurrence or is this a recurrent problem? Your second paragraph expands on the symptoms. Do give as much relevant information as possible. Be concise. For example, no weight loss. This may not be relevant if the symptoms only began 3 days ago. Don't refer to a patient as a bed number, a body part, or pathology. It's not professional to say the fractured femur in bed 3 has developed diarrhea. Don't make your listener ask which eye, how old, how long. Don't leave your listeners hanging. Attendings get irritable when they have to do needless prompting. In medicine, as with most things, it's all about information and communication. Information is key. Get the relevant information and then pass it on concisely and accurately. When you present a patient to your attending or resident smoothly, there's some time for actual teaching and the patient's condition, and you feel like you're part of the team as opposed to just a note taker or a scut runner. Your confidence level improves and you begin to sift out in your mind what is and is not important. So you've done your history exactly as you've been taught, the presenting complaint, review of systems, social history, and so on. That's all great. Yes, you should obtain a social history, a past medical history, and so on. But when your attending says, let's get the short version here, or you have 15 patients to round on, she wants you to get to the bottom line as efficiently as possible. Take as long as you need to get a thorough history, but then present the relevant parts effectively. What is relevant? Well, as you learn more, it will be easier to figure that out. But for now, focus on the presenting complaint and ask yourself, could there be some relevance to the patient's birth order? If you can't think of any, leave it out. Another example, family history is rarely relevant in trauma cases, unless there's a family history of seizures or loss of consciousness. Don't just rattle things off by rote without thinking. Focus on the why. Why is the patient here? And how are all these other pieces of information relevant to that? That way you can figure out what to put in and what to leave out. So now you've taken your history, now present it. Present your patient in a conversational way, if possible. Here's a tip. Smoking is always relevant to everything. So your first sentence should always be, Mr. B is a 40-year-old non-smoker who presents with. If you decide to give this person a prescription, we're going to need to know whether he has allergies or not. So rather than wait for your attending to ask, does he have allergies, and then you have to re-question the patient, just put it out there up front. There's always an onset of symptoms, and it's important to define how and when this occurred. So how about you say, he was in his usual state of good health until last night when he developed, etc. When I present a patient, I want to be concise and informative so that the listener will know everything they need to know to begin formulating a treatment plan for this patient by the time I finish speaking. Do give basic information without needing to be prodded. So here's an example. Mr. Brown is a 40-year-old married non-smoker with no medical allergies, who was in his usual state of good health until last night when he developed a spasmodic cough and shortness of breath. The cough is productive of green sputum and occurs approximately every 15 minutes. The shortness of breath is associated with the cough. Otherwise, his breathing is normal and he has no wheezing. This is the first occurrence of the symptoms. He denies any fever or asthma, and the review of systems is negative. He has no sick contacts. You're done. Now, if the history was longer, you may want to mention he has no weight loss. But for such a short duration of 24 hours, it's irrelevant. Here's another scenario. Mr. Brown is a 40-year-old married smoker with no known allergies who was in his usual state of health until 2 days ago when he developed a spasmodic cough productive of green sputum and shortness of breath. He also feels feverish. He coughs several times a minute and states that he gets these symptoms twice a year. His review of systems is otherwise negative. His co-workers are also sick. Lastly, Mr. Brown is a married 40-year-old smoker with a past medical history of asthma and sarcoidosis, for which he takes Advair twice a day and albuterol inhaler when he needs to. He last felt well 9 months ago, and since that time he has been losing weight and having night sweats. His symptoms changed last week with a worsening of his baseline cough with 2 episodes of hemoptysis. However, he denies shortness of breath, wheezing, and the rest of his review systems is negative. These 3 scenarios point you in a different direction as far as managing Mr. Brown, even though your focused exam will be the same. So here's a summary. Paragraph 1, on everyone. Name, age, marital status, smoker, allergies, medications. The last time they were well, the presenting complaint with the duration and specific location, and is this a first occurrence or a recurrence? The second paragraph, expand on your presenting complaint with a review of systems. Diarrhea or vomiting, how many times a day, has there been any today, is there bloody stool, etc. The presence of fever is always critical. The third paragraph, relevant family history, social history, and other background stuff. I hope this is helpful. If you have any questions, please feel free to email me at drtwalkley@aol.com. Good luck.